This is going to be topic 54, neonatal care, normal childbirth.
Key concepts. Upon completing this chapter, you will be able to understand childbirth as a natural process, potential complications to mother and child from childbirth, stages of labor and anatomical changes in each stage. Chief concerns. Childbirth, a natural process. Most cases require little intervention at all. The paramedic's role in childbirth is to be aware of the normal childbirth process and intervene if complications occur. Anatomy and physiology review. Organs during pregnancy. Many of them change. Most obvious change in the woman's body is the growing abdomen caused by an enlarging uterus. Uteral layers are going to be the perimetrium, the middle layer of overlapping smooth muscle, and the endometrium. Some layers or some structures are actually created, like the mucus plug at the opening of the cervix is formed. Organs related to pregnancy. This is figure 37.1 in your book. Placenta provides nutrition for the fetus and serves as an endocrine organ that secretes hormones and acts as a barrier to potentially harmful substances. Amniotic sac contains the fetus, placenta, and umbilical cord. A complication of this, polyhydramnios, it means excessive amniotic fluid, and this should be talked about in the text. Normal childbirth concepts begins with labor. We can also get kind of false labor called Braxton Hicks contractions, and this is preparatory uterine contractions to kind of get the uterus toned up and ready to deliver, if you will. Signs of impending labor, lightening, descent of the uterus deeper into the pelvis is what this is. Stages of labor. The first stage of labor is effacement, which is thinning of the cervical walls. And then the next area we have dilation, which is widening of the cervical opening. We may get a bloody show with this as well. Rupture of the bag of waters is what all occurs in the first stage of labor. In the second stage of labor, complete dilation of the cervix to the birth of the baby is what we're going to see. And then in the third stage, birth of the baby to the birth of placenta. We get placental delivery in this. The puerperum, fourth stage of labor, birth of the baby to 6 weeks postpartum. And this is where everything's kind of going back to normal, if you will, as in the mother's body. Cardinal movements of labor, figure 37.3. Engagement, flexion, descent, internal rotation, extension, and external rotation. Now, what we get here, let's make sure we have in this first stage, we get engagement and descent flexion. That's where the head actually fits into the cervical area. And in stage 2, we get a kind of an internal rotation where we'll be nose down. Extension beginning and rotation is complete. This is in the third stage here, and kiddo is face down, ready to be delivered. Extension complete, kiddo's head comes out. Extension, rotation, restitution. We generally require maybe a little bit of turning, or the child turns just a little bit when trying to deliver the shoulders. This can also be facilitated by shoulder rotation manually. Support underneath kiddo's head, and on top of support, supporting the head. And then we may actually have to assist in this area here if the shoulders, we get shoulder dissociate. And then 7 is expulsion. Once the shoulders deliver, all the rest of kiddo comes just right out. It's all smaller after the shoulders, so to speak. History, considerations. Primary assessment, history of the pregnancy and labor, the estimated date of delivery, if there's been any discomfort, pain, or labor severity. Whenever the labor started, was there any discomfort? This can be caused by a number of variables. Pain, often described as a backache or menstrual-like cramps, is often seen. Medical conditions and risk assessment, things like pregnancy-induced hypertension or preeclampsia, some of the things that we would consider about in here. If they're taking any medications, do they have any history of diabetes? In their previous deliveries, were they vaginal or cesarean section? When was their last meal, and when was their last prenatal visit? This would all be in medical conditions. Events preceding labor. Was there any bloody show or did they have a ruptured bag of water? Did the water burst? Special case of premature rupture of membranes. Rupture of the bag of waters before the expected date of delivery occurs in about 3% of pregnancies. The primary concern in this is going to be infection, and those are all talked about in the book. Just trying to get you some overall general ideas here. Examination, focus on the supporting the mother's airway, breathing, and circulation. Considerations of this, focus on what's pertinent, protecting the airway, proper draping. Abdominal examination, look for cesarean scars, fetal movement, heart tones, palpate the abdomen, or perform a Leopold's maneuver. Leopold's maneuver, there should be a link on the learning management system so that you can see a Leopold's maneuver performed. It gets you an idea off of general assessment of the abdomen where the kiddo actually is and what part is actually presenting. Vaginal examination is the child crowning and have the bag of waters ruptured. In assessment, considerations, the indications of imminent delivery or the urge to push or move the patient's bowels, coupled with crowning, would be imminent signs of delivery. Are they prima gravida? Is this the first time they've been pregnant, or are they multipara? Have they had multiple children? The multipara prepared to deliver immediately, their body has already been introduced to these hormones before. On the prima gravida, this could be up to 12 to 24 hours, so you might want to go ahead, unless it is giving you indications of being an imminent delivery, go ahead and transport to the hospital. Signals of second stage of labor would be the irresistible urge to bear down or push from the patient's perspective. As far as treatment goes, consideration should be privacy, protect from exposure, position, lateral recumbent position, or alternates to this is have them squat. Semi-seated or semi-Fowler's position is also a good preparation, position preparation. This is table 37.1, child preparation, and things like suctioning, emesis basin, IV access, equipment, appropriate lighting, and then body substance isolation should all be thought about. Privacy drapes, gauze pads, cords, clamps, scalpels, sanitary napkins, plastic bag for placenta, towels, bulb syringe, meconium aspirator in case we do see meconium in the child's upper airway, oxygen tubing for blow by oxygen. A vaginal birth. Considerations on a vaginal birth, reassurance, the process of childbirth is kind of natural. It's been happening for millions of years, thousands of years at least. Breathing techniques, if they have not been coached through this or they haven't been to any kind of Le Mans classes, you might need to actually coach them through panting and blowing. Crowning, when the head starts to emerge. Vertex delivery, newborn crowns head first. Retention maneuver is also in the book, talking about this, allowing the head to gradually extend by exerting gentle control on the newborn's chin, while being careful not to impede the progress. So we want to kind of assist a little bit, but we want to control this process. We don't want an explosive delivery. However, we don't want to impede this process by putting too much counter pressure back. Umbilical cord, nuchal cord. If there is a nuchal cord present, please try to slip it around the child's head. If it's not, and we think that it's giving us problems or going to choke the child or choking the child, please clamp and cut the cord. Baby rotation permits delivery of the shoulder. Once the baby rotates, paramedic cradles the head on either side. Body delivery. The paramedic slides posterior hand down the baby's body, keeping the head supported with the other hand or forearm. And watch out, they are slippery. Vaginal birth continued. Complications. Special case of meconium, or the first stool. Fetus forms a plug to prevent passage of stool while in the uterus. During fetal distress, the plug may pass into the amniotic fluid, staining it yellow-green or even black-green. Meconium aspiration syndrome is an airway obstruction or disruption of the surfactant fluid coating that keeps the alveolars open. Chemical-induced inflammation of the lungs and pulmonary hypertension ensues. Other complications would be like shoulder dyssocia. The shoulders fail to deliver through the pelvic outlet. We can try a Roberts maneuver, pulling the mother's knees up to the chest and allowing for maximum pelvic opening, or kind of a Woods corkscrew maneuver. 2 fingers into the vaginal opening along the fetal scapula, slowly rotating the posterior shoulder 1/2 turn in a corkscrew fashion as the mother bears down. Only should be performed if the McRoberts maneuver fails as well. Breech delivery, what kind of breech we actually get, or is it a frank breech where buttocks present first, or both hips and knees are flexed in the breech? An incomplete breech where one leg is showing or both legs, double footing. Lovett's maneuver, holding down the newborn by the hips, the paramedic turns the newborn in a 1/2 circle like a corkscrew while applying downward pressure. Multiple gestations also should be a consideration. If the mother's abdomen does not reduce in size after the first delivery, consider the possibility of a second infant. Immediate post-delivery care. Grasp the newborn's ankles and shoulders and place the child on the mother's abdomen. Several purposes of this: removes the newborn from fluid and provides warmth. Exercise caution though. Prevent newborn from being below the mother for too long. One of the complications we can actually see with this, it would be hyperbilirubin anemia, and it's an excessive amount of bilirubin in the blood that makes the infant appear jaundice. So look at the baby's color whenever you're doing this and make an assessment. Newborn considerations: dry vigorously with a towel and stimulate the child. Hypothermia. Signs include irritability, lethargy, pallor, and bradycardia and respiratory distress. Acrocyanosis, cyanosis of the extremities is what that is, and they're very temperate. And what I mean by that is if it's cold in the room and they're not warmed up or covered, they will assume room temperature very, very quickly. Kiddos will. So, and they change colors quite rapidly as well. Acrocyanosis can easily occur to the hands, feet, and the extremities because the room temperature is a little cooler. Clamping and cutting the umbilical cord. Normally, there's no need according to the book's text here. However, here in Oklahoma, we do clamp and cut the cord immediately. APGAR scoring, we're going to look at that next. Table 37.2, and this assesses the child's appearance, newborn pulse, reactivity via facial grimace, activity as function of muscle tone, and respirations for APGAR scoring. This is performed at 1 and 5 minute intervals. If we'll notice on this as well, if it's absent, their appearance is pale blue, they get 0. It's not like a Glasgow Coma scale where you get 3 points for just showing up. If the appearance is poor, they're blue and pale, they get a 0. If their pulse is absent, 0. Grimace, no response, is 0. If they're flaccid or just limp, 0. Respiratory rate, absence, 0. And then the scores for a 1 and the scores for a 2. Please review this. You'll need to do these quite rapidly, and this will figure out whether or not that you have any kind of fetal compromise at all. Let's go to the eraser. All right, delivery of the placenta. Last stage of labor considerations. Signs of placental separation, small trickle or sudden gush of blood, and or lengthening of the umbilical cord as it extrudes from the vagina. Avoid aggressive traction on this. May result in pulling the cord off the placenta, leaving the placenta behind. Guard the uterus. Place a hand above the symphysis pubis on the mother's abdomen and encourage the woman to push. Once delivery, examine the margins. The placenta itself should be relatively smooth and make a complete oval or circular shape. There should be only one area that looks like it's the area where the placenta attached to the uterine wall. So that's the only area that should be rough looking at all. As far as the rest of it should be nice and smooth and look like essentially an organ. Maternal hemorrhage, the major causes of hemorrhage. Risk on this is the uterus does not contract or you have uterine atony. Causes of maternal blood loss. They retain products of conception inside there, an incomplete placental detachment, lacerations to the vagina or cervix, and maternal clotting disorders can also kind of cause lots of maternal blood loss. Steps in controlling the maternal hemorrhage: perform uterine massage. If the uterus does not respond to the uterine massage or the hemorrhage is severe, encourage the mother to nurse the newborn. The nursing newborn will initiate oxytocin, which will actually make the uterus contract even more, which will assist all the products of birth out of the cervical area. Very rare. This is an amniotic fluid embolism. Very rare, 80% mortality. Amniotic fluid and fetal debris enter the central circulation. Onset is sudden and unpredictable. Treatment of this is generally supportive, rapid transport, or standard resuscitation techniques. As far as disposition goes, transport the woman and the baby, mother holding baby skin to skin, breastfeeding if desired, documentation after transport, the estimated date of delivery and the time of delivery, initial APGAR scores, 5-minute APGAR scores if you're still with the kiddo during that time, appearance of amniotic fluid, the presence or the absence of a nuchal cord are all important as far as documentation goes. In conclusion, normal childbirth, wonderful events that some paramedics are called upon to share with expected parents. Most pre-hospital deliveries tend to be uncomplicated. Paramedics are well equipped to handle and assist in the process of normal childbirth, as well as any complications that may arise.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith. Smith or at SamaritanEMSOK.com or 405-492-8243. Thank you.